Retinopathy of Prematurity, ROP, a retinal vascular disease characterized by abnormal angiogenesis in premature infants, results from the disruption of normal retinal vasculature development. Previously termed retrolental fibroplasia, RLF, became a significant cause of blindness in the 1950s with increased survival of premature infants. Historically associated with high levels of unmonitored supplemental oxygen use. A leading cause of childhood blindness worldwide, particularly increasing in emerging countries. Pathophysiology involves abnormal expression of vascular endothelial growth factor, VEGF, develops due to incomplete retinal vascularization at birth in premature infants. Phase 1 involves arrest of normal retinal vascular growth, potentially related to relative hyperoxia after birth. Phase 2 involves pathologic neovascularization driven by subsequent hypoxia in the avascular retina. Low gestational age is a primary risk factor, with risk increasing as gestational age decreases. Low birth weight is a primary risk factor. Prolonged or fluctuating oxygen exposure increases risk. Poor postnatal weight gain is a significant risk factor, possibly linked to low insulin-like growth factor IGF-1 levels. Neonatal sepsis is associated with increased ROP risk. Histologic chorioamnionitis is associated with increased ROP risk. Other potential risk factors include increased illness severity, mechanical ventilation, and blood transfusions. Classified internationally by zone, location, stage, severity, extent, clock hours, and presence of plus disease. Zone 1 represents the most posterior retina centered on the optic nerve. Zone 2 represents the mid-peripheral retina extending from Zone 1. Zone 3 represents the far peripheral, crescent-shaped area of the retina. Stage 1 shows a thin demarcation line between vascular and avascular retina. Stage 2 features a raised ridge developing from the demarcation line. Stage 3 involves extraretinal fibrovascular proliferation, neovascularization, extending from the ridge into the vitreous. Stage 4 involves partial retinal detachment caused by traction from the fibrovascular tissue. Stage 5 signifies complete retinal detachment. Plus disease indicates increased dilation and tortuosity of posterior retinal vessels, signifying active, severe disease. Aggressive ROP is a rapidly progressive form, often posterior, requiring urgent treatment. Screening via dilated eye examination by a trained ophthalmologist is crucial for timely detection. Screening typically indicated for infants 1,500 grams birth weight or 30 weeks gestational age at birth. Screening may include selected larger or older infants with unstable clinical courses or based on regional guidelines. First screening examination timing is based on postmenstrual age, typically around 31 to 33 weeks PMA or 4-6 weeks chronological age. Follow-up exam frequency depends on findings, ranging from weekly for high-risk findings to every 2 to 3 weeks for stable immaturity. Telemedicine and artificial intelligence show promise for future ROP screening, but face logistical barriers. Most ROP cases are mild, stage 1-2, and regress spontaneously without requiring treatment. Treatment aims to prevent progression to retinal detachment and subsequent vision loss or blindness. Laser photocoagulation ablates the peripheral avascular retina, reducing the production of angiogenic factors like VEGF. Laser ablation is considered the standard of care for treatment requiring ROP. Treatment indications, type 1 ROP, include specific combinations of zone, stage, and plus disease defined by the ETROP study. Intravitreal injections of anti-VEGF agents, e.g. bevacizumab, directly block the action of vessel growth factors. Anti-VEGF therapy is increasingly used as an alternative or adjunct to laser, especially for posterior Zone 1 disease. Anti-VEGF treatment requires prolonged follow-up due to the potential for late recurrence as the drug wears off. Infants treated for ROP require long-term ophthalmologic monitoring for visual complications into childhood. Potential long-term complications include refractive errors, especially myopia, strabismus, eye misalignment, and amblyopia, reduced vision in one eye. Strabismus is more common in premature infants, especially after ROP, intracranial hemorrhage, or white matter injury. Risk of blindness after treatment with laser or anti-VEGF exists, but is relatively low, e.g. 2-9%. Prognosis for good vision is poor with stage 5 total retinal detachment, even if surgical reattachment is attempted. Untreated stage 5 ROP typically leads to no light perception vision. Severe ROP stage 4-5 or ROP requiring treatment is an independent predictor of poor long-term neurodevelopmental outcome. Timely arrangement and completion of screening and follow-up appointments are critical to prevent adverse visual outcomes. Sources: Klaus and Fanaroff's Care of the High-Risk Neonate, Gomella's Neonatology, Avery's Diseases of the Newborn, Perinatal Medicine, Diseases of the Fetus and Infant, Fetal and Neonatal Physiology, Essential Neonatal Medicine, Manual of Neonatal Care, Clordy and Starks, Volpe's Neurology of the Newborn,